welcome back. Welcome to the Eyecare experts, Dr. Bell, Dr. Terrezza, and we have Dr. Sahawneh with us again. We're just going to jump right into it. The topic of today is geographic atrophy. I know certainly online I'm starting to see a lot more commercials for GA, how it affects the retina, how it relates to macular degeneration. So there's a lot of, I guess, I don't want to say new information, but certainly it seems like it's a little more prevalent nowadays.
More awareness.
Yeah, more awareness.
I have more patients coming in who are asking me more questions because of the commercials and the things they're seeing.
That's a good way to put it, yeah. Well, as far as GA, I'll just turn it over to you. Where do you want to take it on?
Well, geographic atrophy, this is regarding the retina, the back of the eye. It's called geographic because it resembles a map. So there's an area that the cells die and you just don't see well. And you want to stop that process as soon as you can, which gets back to something Dr. Bell is fond of, and that's early detection. And then because if you can put it out with a hose when it's just a campfire, it's better than a 3-alarm fire. So hopefully, over the age of 55, realizing that macular degeneration is the #1 cause of blindness in the United States, that people will be motivated to come in and get checked and make sure they don't have that, particularly if there's a family history of the disease, because the genetics are complicated, and I don't really have a handle on that. But your chances are good that if it runs in your family, you have a shot at it. And of course, if you smoke, you're 2.5 times more likely to get it than someone who doesn't smoke.
Well, I think we could have the leading experts up here, and I think the exact cause of geographic atrophy is up for debate. But I think they would say certainly aging plays a factor, oxidative stress factors in there somehow, genetic factors, which you mentioned, and inflammation all kind of correlate. But as far as the exact cause or why one person gets it and the other one doesn't, I think there's a lot of grayness there.
Yeah, they do know there is part of it is an immune response to certain triggers or stress in the retina, and that's something that some of the newer treatments out are looking at the immune response inside the macula and on the tissues. And so I think that's something that's really fascinating, that they're finding certain pathways that become really overactive within that macular tissue. They can isolate the protein cells and all the different pathways and say, this is the one that's overactive, this is what we need to block, to try and help prevent that from worsening and from those cells attacking themselves, essentially.
Well, 30% of the dry AMD patients will progress, regardless of what they do, to geographic atrophy. So the sooner you get it, you can slow that process down. You can't stop it, but you can slow it down.
Mm-hmm. That's something that, depending on what specialist you talk to, but they would almost argue that it will progress. You just don't know how quickly and how fast or how long you're going to have certain types of vision, that it's not going to get better. We just hope it doesn't progress really quickly, but that ultimately we know it will progress. And so that's where looking at those ways to prevent it, modify it if you can, like that.
And, as far as this and other conditions we treat, keeping it stable or as close to stable year after year is sometimes the best we can offer. Mm-hmm. Just keeping it slow, keep that dry where it really doesn't affect you, and just kind of keeping that slow moving for as long as we can.
Yeah, and slow moving, when we're talking about slow moving as far as how to measure that, is a lot of times it's done in lines of acuity. So when we're having you read our eye charts, we're able to really kind of measure how quickly and how bad is that progressing based on where is your central vision and how badly is it becoming worse, or how quickly are you losing lines of vision, or how, unfortunately, how each eye is taking on its own. Because if it's happening in one eye, it's usually happening in the other, and that's the more devastating thing. I think it's 2/3 of people with geographic atrophy have it in both eyes, and that if it worsens in one eye, it will worsen in the fellow eye eventually.
Well, I know since we started our career, we used to refer, more patients at an earlier point that had macular changes, atrophy, degeneration to retinal specialists. But now, with the advances in OCTs, the advances in maculogic, the advances in foresee home binodal vision, we're able to track it in-house and keep a close watch on it, and then kind of figure out the right time to get that patient to the retinal specialist to be seen. And the great thing with all of us, and certainly our practice, is we have great relationships with all retinal specialists in the area, and we certainly want to get them, get the patients to the retinal specialist when that need arises.
And I will say, when we were seeing dry macular degeneration, geographic atrophy, even when I graduated, there wasn't really an answer other than to just watch someone slowly lose their vision. So it is nice that I can have more of those conversations and get them to the retina specialist earlier to say there are new options out that can potentially help you. You might be a good candidate for this, and that I'm having more of those conversations because there are new medications, new FDA-approved treatments that are out now. So I am trying to get them to the specialist to have that consultation sooner, because that's something a couple years ago we weren't really able to do.
And the other thing is, there's things that I think a lot of people kind of blow off sometimes with the eyes. Hey, it's a little blurry, or hey, I think it's going to clear up in a week or two. But these are things where if it's significant and you're noticing it, whether it's blurry or a spot, or hey, I was fine yesterday, but today I can't see this, don't let it slide. Come in and see us. We have office visits. We usually can work you in if it's serious the same day, or within a few days. These are things we want to look at, and we want to detect it as early as we can and help you. We certainly don't want it to be there and you come in and say, hey, well, this started a month ago, or this started 6 months ago, or a year. The earlier the better. So certainly give us a call, because we want to check it out and get you to the right person, get you treated, get you, on the right supplement, the right treatment, the right plan, whatever we need to do.
And one of the things with that, our older generation, a good majority of the patients have had cataract surgery, and cataract surgery is considered now a risk for developing ARMD. And great numbers of people have that and should be followed as a function of that.
Well, I will say that even just along those lines of post-cataract surgery is still making sure you're wearing your sunglasses, you're still having those routine checks. I know once we get our post-cataract surgery eyes, we're just usually pretty thrilled with our vision, and to the point where they're like, oh, I'm good to go. Don't have to see an eye doctor again. We're good.
I'm good.
You still need to watch those retinas and still make sure everything is healthy in there.
And this, geographic atrophy is a progressive condition, right? So, maybe the signs are very mild at this point. Maybe you're like, hey, this isn't that big of a deal. But certainly, whether it's GA, whether it's macular degeneration, whether it's glaucoma, these are conditions that are going to get worse. They're going to progress over time. And the longer you blow it off, I can't tell how many times I see patients and they think, man, I should have came in sooner, or I didn't think it was that bad, so I didn't come in. And just, we've said this many times, but certainly come in. If it's bothering you, it's bothering us. We want to try to treat you. We want to help you. And the earlier we can detect and find out these conditions, the better the results usually are.
I will say it's also interesting how many patients don't actually have a complaint or have symptoms until they're in our chair and our technicians are asking them to cover one eye and then cover the other, because your eyes do help cover for one another. So if you have one really good eye and the other eye is the one having the symptoms, sometimes you don't notice. So I would almost challenge everyone to go ahead and cover one eye and cover the other eye every now and then, just to make sure everything is still looking good in each eye individually. Because I will say sometimes we have that show up right there in the chair and a patient is very alarmed because they haven't ever done that. And that's something that just at home you could do that and see how you're doing.
Well, speaking of that, I think the patients, I worry about everybody, but it's certainly the ones that I worry about the most are the ones who've already lost an eye, whether it was wet macular degeneration or something there, and they've only got one eye left, and they realize at that point the seriousness of it, and doing all we can to try to save that one eye, the central vision, that one eye, and maintain that the best that we can. And what we're saying is we hope you don't get to that point. We hope no one gets to that point. But certainly, give us a call.
And if that is something that we are at that point, not all hope is lost. There are a lot of modifications in your lifestyle and what you're doing with your reading material, your lighting, the way you navigate your home, the way you get around town, the way you get your day-to-day activities done. We can help you through that. And that's something that if you do end up in one of those low vision categories or you need extra help, extra magnification, that's also what we can help do, because it's not just one and done, this is your option, but we can also help when you do get to those points of of needing more help. That's something that we also are very passionate about that. So we want to prevent it, but if we are at that point, just know there's still options to help you.
And the literature points, I think it's more, a higher percentage in women than men as far as GA. I think that's
Always,
true.
of course.
But I guess the other thing I get sometimes is, oh, I just had an eye exam a year ago or 5 years ago, and they said everything was good, right? Well, we hear that all the time. Well, we're talking about a condition that sometimes doesn't even present itself to maybe 50s, late 50s, 60s. So, yeah, maybe you had the best eye exam ever a year ago, and they dilated you and they checked the health of the eye. But that doesn't mean you're 100% out of the woods. I always tell patients, hey, you know, you're this age, maybe you're 70% out of the woods or 90% out of the woods, but you're not 100% out because it still could happen. It still could occur, you know, at a later time.
Well, I just printed this list out from the American Optometric Association on conditions that favor your development of macular degeneration and the progression of geographic atrophy. Smoking, obesity, cardiovascular disease, sleep apnea, poor diet, diabetes, high cholesterol, long-term use of calcium channel blockers, and then it lists all the medications. I didn't want to get into that.
Yeah.
So that's a huge audience out there that requires this. That's why it's the #1 cause of blindness.
Yeah, that's a list. I mean, there's a lot of things in there. I mean, and we take just sleep apnea, for example. That's one of the things you mentioned. Just, you know, it's not necessarily nowadays how many hours you get sleeping. It's the quality of those hours that you're, you know, and a lot of things factor in. Weight, you know, as far as breathing, sleeping. Are you getting oxygen deprived? Are you getting what you need? And a lot of people don't realize how that affects the eyes and affects everything else with the body.
I will say that I think sleep health and sleep hygiene there's more awareness of that too, with different, you know, watches, ring technology, things like that are monitoring and helping people kind of be more aware of their sleep habits, especially with screen time, things like that. There's a lot of research coming out that sleep is one of the most basic foundations to all of the other risk factors or other diseases, and that is something that I think even in eye care, you don't think about eyes and sleep going together, because when you sleep, you close your eyes are done, but it is something that overall is going to help the restorative health of the eye. It's going to help protect those healthy retinal cells. It's something that all of that oxidative stress that we put ourselves under all day, sleep is going to go in and help undo that, and it's something that is very undervalued. And as a new mother, let me tell you.
It's valued with you. So you're saying there's watches that keep track of how long you sleep and your quality of sleep?
Oh,
is what you're
yeah,
saying?
watches, rings, all of that. It's fascinating. It will give you sleep scores. It will tell you your body temperature, all of it throughout your whole night. Even my baby, they have them for babies. I have one on my baby. I can tell you how she slept through the night. I can tell you how she didn't sleep through the night.
So
Do
maybe
you have one of these watches?
No, I'm waiting until they put them in eyeglasses.
They probably will at some point.
Well, we've
A
got
sleeping
hearing
mask.
aids. We got hearing aids. We
do have hearing aids
We got
and glasses, yeah.
we got meta glasses already. We got a lot of
Yes.
stuff already. And our Ray-Bans and Oakleys, a lot of things you can do. It's crazy.
I will say that in the eye world, there's so many new advances every year. New eye drops, new technology, new injections, new glasses. We have new toys for us to diagnose things on people. It's pretty advancing. So even if you have an eye exam a year ago, there's going to be new stuff that comes out year to year.
I know we've said before with some of the, and we're always trying to stay on top of getting the latest and greatest equipment, but some of the equipment has gotten so good nowadays where we can diagnose things so early, which is good, but the treatment sometimes, I think the treatment side has got to catch up with the diagnostic side. It seems like that's lagging behind, which it comes, and they correlate together, but sometimes we're diagnosing things so early where all we can do is kind of watch it or do this or that, but there's really no treatment in place for someone that's got such a mild condition.
And I think that's something that some patients don't know, that like insurances, when we're talking about insurances using benefits by the end of the year, so much of that can go towards preventative testing, it can go towards medical testing, it can go towards these treatment plans. All of that can be utilized. And so that's something that it's impressive how much coverage patients can get just by coming in and doing a routine exam and just seeing what we can do for them.
And, you know, whether you have a vision insurance or whether you don't have a vision insurance and you just have a medical insurance, pretty much everything we've discussed here would fall under your medical insurance. Any medical diagnosis we find, we could bill your medical insurance. Whether you have a flex spending or a health spending account, certainly the holidays are coming up. We're, November, December, end of the year. Some of those things you've got to use before the end of the year. You can spend it on frames, you can spend it on contacts, you can spend it on sunglasses, and they don't even have to be prescription sunglasses. They could just be a regular pair of sunglasses. But there's a lot of things to spend it on. Come see us. Whether it's, you have atrophy, you have family history of anything like that, we want to be able to certainly watch it, assess it, treat it, and handle things the right way. But we appreciate you watching. Certainly comment. If there's any topics you want to hear from us in the future, let us know. But for Dr. Bell, Dr. Terrezza, and Dr. Sahawneh, thank you guys. Thank you.